This is the future of medicine.
The bell curve is a great construct, but it doesn't really account for the tremendous differentiation in the 3 billion base pairs of our DNA. But as we gather more information to the point where it exceeds the amount for an ordinary human being, even a very talented doctor to ingest, we kind of clung too long to that medicine of the averages when all of us are different, very, very different. And so that was kind of the premise of my trajectory of research was, as a mathematician, how different are we? When you start thinking about that and then add AI, which can synthesize all that data, we start to come up with insights that are revolutionary.
It seems like the way that medicine is practiced is done with the intent to do the best thing for the most number of people. It's just that I'm not the most number of people. I'm an individual.
And that's where we get it wrong, is so many things are different in our DNA. When you compound that with the massive variety of environmental and lifestyle triggers, that fundamental average, medicine of the average, no longer works.
We can jump you closer to the optimal finish line for you to start feeling better. I love that in your upcoming book on precision medicine that you tie in the role of AI. It's a real solution, and that's life-changing. Welcome to Saving Sapiens. Today, we are excited to welcome Jim Wallace, author, CEO, and healthcare strategist. As a Harvard senior researcher, a former SpaceX executive, and healthcare CEO, Jim Wallace challenges the averages that have defined traditional medicine and paints a future powered by data, autonomy, and personalized care. This is the future of medicine. Welcome to the podcast, Jim.
Thanks, Matt. It's great to be here. We're making tremendous strides, and the future for precision medicine looks really bright.
Can you give us a little bit of a description of why and how medicine has depended on these discoveries of averages, the establishment of these sort of baseline standards of care, and what that does to patient care? Is that in the best interest of our patients?
Sure. Without nerding out, and I'll ask you to kind of guide me if I start to, the entire healthcare system, if you trace it back to Mendelian genetics, if you look all the way back to the early studies in the original hospitals, which were hospitality centers, not medical. They were places where people would go to be hoteled in while they were sick and things. It really revolves around this central concept of what's normal. Well, normal is, as Nassim Taleb would say, it's wrong. You're fooled by randomness. The bell curve is a great construct, but it doesn't really account for the tremendous differentiation in the 3 billion base pairs of our DNA. So everybody's different. That was a necessary step for research and to finance care, to create a transaction between a doctor and a patient. You had to be able to say, well, this is what I'm aiming to do as a standard. But as we gather more information to the point where it exceeds the amount for an ordinary human being, even a very talented doctor to ingest, we kind of clung too long to that medicine of the averages when all of us are different, very, very different. And so that was kind of the premise of my trajectory of research was, as a mathematician, how different are we? Well, it turns out that the course of care, while the FDA might underwrite something to 1.96 standard deviations from the mean, that outlier, those are really, that you're fooling yourself, because everybody is an outlier somewhere of your DNA. When you start thinking about that and then add AI, which can synthesize all that data, we start to come up with insights that are revolutionary, that literally leapfrog, that they make the last mile, which generative AI is really focusing on now, of communicating between the doctor and the patient. They make that seem relatively minor, because you could get in front of it before you ever had to have the conversation about how'd you get pancreatic cancer or something like that. Does that make sense?
If we're being told we need a medication to manage hypertension, a lot of times it feels like the doctor is finding the thing that has worked on average for the longest amount of time for the most amount of people. But I know as an individual, I might not fit into that average. And it seems like the way that medicine is practiced with meaningful standards of care is done with the intent to do the best thing for the most number of people. It's just that I'm not the most number of people. I'm an individual.
Exactly. That's exactly right. I was speaking with a company recently that had identified within the class of patients, the category of patients that were diabetic, that slightly over 2/3 of the diabetic manifestations were driven by a behavioral health disorder, and yet they were treating the symptomatic output when the cause was really a mental health issue. And so when they started acting on the mental health issue, the activity that was producing, the sedentariness or the, overconsumption of sugar or any one of those, 2/3 of the time was being triggered by a mental health disorder. And when they started treating that, the diabetes came back into line. I think we're seeing this among and outcomes from the GLP-1 agonist, Wegovy and Ozempic type of experience now. When you change the hormone that causes you to maybe overeat, losing weight, your cholesterol comes back into line, your blood pressure comes back into line, which isn't really an advertisement so much for the GLP-1. It's more pointing to what's the primary cause that's causing the host of symptoms. And that's where we get it wrong, is so many things are different in our DNA. I know this is a favorite topic of your podcast. So many things are different in our DNA. When you compound that with the massive variety of environmental and lifestyle triggers, that fundamental average, medicine of the average, no longer works. It was a necessary guidepost along the way to understand a disease, but it just doesn't work when you start factoring all those things in. And one of the stories that I like to tell that really got me started on this was my 87-year-old mother-in-law. She clearly has experienced tremendous acceleration and advancement in medicine over the course of her life. But one day she got a blood chemistry report sent to her from a physical that was written in such a way that she could deduce the outliers on her blood chemistry, figure out what was wrong just from the very little verbiage in the report, and then sought out her physician, went to the physician's office, and the doctor did not have the report yet. And on being presented with the report, actually started to kind of undermine what was in that report. Not an indictment of the doctor, it's an indictment of the system that causes that doctor to put my mother into standard care pathways when there was enough information for her to take her healthcare into her own hands. And my doctoral work was an internalization versus externalization. Once you cross that barrier and the patient starts advocating for themselves, the symmetry between the doctor and the patient goes off the chart in good ways, and their outcomes reflect that. 37% of health outcomes are driven by that symmetry between do you believe the doctor? Does the doctor believe you? And that's another failure of the medicine of the averages, and it's reinforced by value-based care. Value-based care says, do this and I will reward you handsomely. What it doesn't say is, do this other thing and you'll avoid the condition altogether. It's frustrating to the point of infuriating. How does that resonate with you as a physician?
I love that idea of actually understanding how the patient arrived at the symptom and fixing that or even preventing that, rather than just asking what's the best average way to treat a symptom. Because I feel like in medicine, we are almost forcing ourselves into a pattern of care that we would never accept for any other industry. If
Yes.
you took your car to a mechanic and the mechanic said, well, your car doesn't run and their car doesn't run and their car doesn't run. And so they're proposing to say, do an oil change on all of them because just, hey, maybe that's why it doesn't run. You would never, ever take your car back to that mechanic if they just assumed everybody's cars didn't run. And so we should do the same thing to all of them, rather than pausing, figuring out why the different individual unique causes of each problem with each automobile was occurring. That's what we expect from every other approach when we are trying to fix a problem, where we know that even if a systemic outcome of a problem is similar, it doesn't necessarily arise from the same cause. And that's incredibly important, because in medicine, when we don't figure that out, the patient just ends up suffering more. When you have a
Yes.
patient, like when you mentioned some patients, when they receive the proper healthcare for behavioral health, or when they receive the proper, it can sometimes be something like food support or other kind of environmental or social conditions that need to be in alignment. That can be the preventative, rather than just saying, well, you have this symptom just like these other people. Let's go ahead and get you on the same medication that has done the same thing on average.
Yeah. Yeah, that's a great point. Two corroborating perspectives on that. In one of the earlier eras of healthcare reform, I was the head of strategy at Anthem, and we were looking at the business, trying to figure out what's the right thing to do. Is kind of where we started the question, and we said, let's just take the boundaries off utilization management and let doctors practice in a way that once you touch the patient, you own the patient forever. So we introduced longitudinality, and then we put all the doctors in a risk pool. It was before ACOs were authorized, and a wonderful thing happened. As we shared data before we had AI, the physicians started acting collaboratively to prevent and get in front of certain conditions. So the cardiovascular surgeon was no longer compensated on doing a coronary artery bypass. They were compensated on preventing one. Well, healthcare reform didn't come to pass like that. A different version came out, and that all came unwound. Well, now AI is making it abundantly obvious that we can do that. And so I'm hopeful that value-based care will kind of turn a right angle, see that if we invest a little bit up front, we'll avoid the nastier things in the back end. That's really what we have to do. And I'm comforted because we are actually seeing Wall Street and financiers of care, payers now that they have that data, they kind of have to do something with it. An example is DecisionRx, one of the companies that I work with. I was the inaugural CEO. We recruited the team, and now it's doing great things. 100% of human beings have something in their DNA that prevents metabolization of some drug. Well, if you go down the ordinary prescription pathway, we talked about this beforehand. If you're a Southeast Asian male, just by virtue of your haplogroup, you're likely to not be able to metabolize warfarin. That's the poster child example inside the industry. So why start there? You should not, right? That's, I think, the combination of data with the integration layer of AI is now allowing us to see a lot more clearly, more quickly, what the right path of care is, which is liberating doctors to do what they feel should be done, and wonderful things happen cost-wise. I don't know how that sits with a lot of your listeners, but I get some pretty screwy looks from payers and providers when I say, we're not going to tell you what to do. We're going to arm you with insights that say, this person can't do this, or this person can do this, but we trust you. What's your reaction to that?
So when the example that pops into my mind, where this kind of extra layer of data and extra layer of personalization can literally mean life and death change for a patient, is in the setting of psychiatric care. When a patient comes into the clinic and they are facing major depression, and they're given a sort of standard series of trials with a drug like an SSRI, a selective serotonin reuptake inhibitor is classically a good first drug to treat major depression for the average patient. And when a patient doesn't respond well, there's this built-in lag time of several weeks when nearly nobody responds well. And then we can sort of tell if it's going to be an effective medication several weeks after the initiation of treatment. If you're a patient who is having their life disrupted by major depression, the idea of waiting maybe 6 or 8 weeks to find out if the drug is even a good fit for you can really be disruptive. It can be devastating, and in some cases even worse when patients are really facing serious depression. And the knowledge that we now have that there are these personal differences, that when I sit down with you, just by looking at you, I can't tell whether you are going to hyper metabolize this drug
Mhm.
and get it out of your system too fast, hypo metabolize it and maybe get too much of it on a standard dose, or just metabolize it sort of at an average rate. I can't tell that. And so I can't predict, unless I actually access that personalized data, whether this is going to be good. And when we arm physicians with this information, when we say, you know what, here is a genomic screen that tells you this patient is more likely to respond to this category of medications and less likely to respond to this category of medications. I now have the potential to skip a very,
Yes.
very difficult 6 to 8 weeks for my patient and get them closer to connecting to a medication that works. And for some patients, this can be life-changing because there are patients who are put on a trial of one drug and it doesn't work for them. And they're put on a trial of a second one and it doesn't work. And then maybe the third one after 6 to 8 weeks more is now making them feel better. But for sometimes 2, 3, 4 months, they're suffering through this series of uninformed trials where we're
Yes.
not sure if you're really like the average patient on the average drug, but maybe you are and maybe you're not, and we'll see. And we don't have to necessarily wait for that anymore. We can jump you closer to the optimal finish line for you to start feeling better. And
Yes.
that's life-changing.
Yeah, no, that's I've had the pleasure of working in a number of domains, and when I was the head of business development at SpaceX, we used to plan for rapid unscheduled disassemblies, the RUDs, where the you test a system to the point of failure. Can't really do that when the patient's, or you should not do that when the patient's quality of life is in jeopardy. And so pharmacogenomics is one section that I researched in the book, and that's life changing. 16% of the $4 trillion US healthcare economy is directly attributable to prescribing the wrong medication. 500,000 people, 17% of the people that die each year in the US die either directly or indirectly because they were on the wrong medication. So it's literally life changing, like you say. But there's also other things. Wearables now, I'm aware of a research study that just by tracking the information on an ordinary Apple Watch, fibromyalgia incidents, which has previously been thought to be idiopathic, can be predictable based on activity a day and a half prior to the flare up. Now, the traditional response to that is to prescribe Neurontin or Lyrica or something like that, which treats the symptom. But if you begin to understand what causes the flare up and you can moderate your lifestyle to avoid that, then you've tamed fibromyalgia. Another section of the book is on just pain management generally. So much of that is driven by lifestyle considerations like average accepted toxins in levels that exceed someone's adaptability to it, because we all vary in that are in your everyday cleaning supplies in an ordinary restaurant or a home. Things like anti-fatigue maps, that's that just because you stand a lot in your job, you can change what you stand on with an anti-fatigue mat and change so much in the transmission of pain through your body. That's a big data thing that we really didn't understand until we saw enough cases of that to say, you're just like this other individual that had the same issue. The danger there is, what did I just do? I went back to the average and said, you look like so much like this other individual. That's the danger of big data, is saying, well, you look a lot like this. But AI breaks through that and says, at kind of the granular level, you're the 5% that can't tolerate this compound in the dishwashing detergent that we use in a restaurant, and you're on your feet all day, and you hyper metabolize the pain medication that we were giving you. That's why you never could get rid of the pain. And by addressing it at its source and getting rid of the drug that's not useful, the person restores a quality of life that's normal. There are so many instances of that in the four main drivers of precision medicine: wearables, genomics, big data, and AI. Those two data inputs combined with the two integration layers now make preventive medicine a lot more cost effective. And that's kind of what I'm evangelizing. It's what, Epic has done great things. Judy Faulkner will be remembered for a long time on what Epic was able to bring to continuity of care inside of episodic treatment. But it's now the dinosaur. And firms like Persivia and Innovacer and Arcadia, platforms that are utilizing AI to get in front of it instead of treating it so that it's longitudinally. That's the next. If we can just convince Wall Street to stop trying to create the fourth generation titanium hip for somebody that's unfortunately, has a 1 year lifespan anyway. I'm not saying don't do that. Let's prevent the deterioration of the bone condition. Let's, instead of adapting to it after it's occurred. I can see that's probably center bullseye in your evolutionary biology sphere as well. What are your thoughts on that?
The advent of the things that sound exciting tend to either be end of life care where somebody's either has a chronic or traumatic injury, or at the opposite end, what a lot of younger patients are getting into is these enhanced capacities for gathering their own personal biometric data through
Yes.
something like wearables. The overwhelming thing for physicians can end up being where you fall in the middle, because you want to give the best care you can to patients in their later years of life, but you also want to encourage younger patients to value the kind of lifestyle modifications and dietary choices and patterns of physical activity and sleep that encourage them to not develop those chronic conditions. But you run into this bottleneck, right? Where the therapies available for later life are getting more frequent and more expensive, more fancy, more investments in sort of late life care. The investments in earlier preventative approaches to health are either lagging or they're flooding us with information. And I think this
Yes.
is the breakthrough moment that I love, that in your upcoming book on precision medicine, that you tie in the role of AI, because it's not just about it being this flashy term like, hey guys, look, now we have technology like wearables and AI. It's a real solution for an intractable problem. The better I want to personalize your care, the more information I need about you. I need more genetic information to know kind of what biological baseline you're bringing in to the clinic. And I need more biometric data to know how things are going for you on a day-to-day basis when you're not in the clinic. What has been going on? Have you been sleeping? How has your blood pressure been? On average, those averages for you matter more than the averages for the population. But if I only have a little bit of time to see you in the clinic, I'm going to drown if I have to not only talk
Yes.
normal clinical medicine with my patients, but if I have to also now understand what their 3 billion genetic base pairs telling me,
Yes.
and what are their reams of biometric data telling me that are updated on a minute by minute or hour by hour basis, and that kind of overwhelm that the doctors cannot conquer on their own, finally has a real potential assistant, a sort of master evaluator with AI. Talk to us about why that is such a massive breakthrough.
Yeah, no, thank you for bringing that into the discussion. I think what AI does in the last mile or 10 feet or inch of communicating, helping a doctor communicate better with a patient is very important. But that's trivial, to be candid. But a lot of money's flowing into that. Using AI at the early level in deducing future problems and orienting the physician is super valuable and super important, but the most abstract to understand right now. Tempus AI is doing that very well with cancer. But it's probably at the intermediate level that synthesis of reams of data. The Medtronic Chronicle, the first implantable diagnostic device for congestive heart failure, failed because it was sending pages to doctors in real time when someone had an aberrant biometric response. It failed. $200 million investment down the drain because the doctors weren't able to ingest that data. That intermediate layer that identifies signal from noise and then alerts the right party longitudinally in the course of care. This is a concept I introduced in the last section of the book. Primary care of today is still episodic. Come and see me when you have a problem. Preventive and precision medicine of tomorrow really disaggregates that into a clinical professional who is expert at identifying onset, a clinical professional who's better and more focused at managing onset. I call that an acutist. And then a clinical professional who's better at managing the stabilized state, a chronicist. And then on top of that layer, you have cognicists who deal with the behavioral health issues that manifest as physical. But that's a longitudinally developed care system. That means quite a lot of things for a primary care doctor, because now you're not Now you're more Marcus Welby from that series in the 70s, where you're synthesizing a lot of data. There was a lot less then. And you're acting more as a life coach uh, in getting in front of things. That's what I think is going to evolve. And if we let go of value-based care, trying to jam that square peg into a round hole and force doctors through a medicine of the averages reimbursement system, that's what will naturally come about. In the systems that I've researched, that's where it kind of turns. You might have an RN or a PA doing more of the pharologist work on the front end, and then having a what we call today a standard primary care physician doing the acutist work of, okay, what do we do about it now that it's occurred? And then introducing a surgical anatomical expert in an anatomical system. Surgeons are not going to go away. But that's really how you would approach longitudinal care. And as mathematicians, the two of us, we can kind of see that linearity. As a business professional and an engineer, I can see that linearity. That's almost the antithesis of what value-based care tells you to do today. So that's a pretty heretical concept, because I think I probably alienated the AMA, and the insurance companies. But the patients that I've seen exposed to that are a hell of a lot healthier, because they're engaged earlier at the right points in time to avoid those things. And it just magnifies health efficacy. It magnifies the internalization. It magnifies and amplifies the doctor-patient symmetry in ways that unleash health instead of treating sickness.
Well, it's so exciting to think from the patient perspective. If we ignore the disruption we cause systemically by proposing this sort of prevention upfront at a personalized pace,
the Hippocratic Oath.
It's so exciting. If you imagine as a patient getting the kind of personalized guidance that says, hey, with your current sleep and activity level and your genetic risk factors and say your diet, your lifestyle, your exposure, maybe your gut microbiome makeup, your probability of developing type 2 diabetes is 48% over the next 2 years. If you could get down to that kind of predictive precision medicine by having that sort of global evaluation of your particular specific unique individual risk factors, you're empowering patients to get ahead and say, you know what, I am not comfortable with having that kind of a high risk of developing something like this, and then giving them the personalized tools to help them avoid that, right? Like when we approach medicine as helping patient outcomes in the long run, rather than waiting until a symptom presents itself in an intolerable way and our patient shows up miserable and ill, either in the emergency department or their primary care office, we're disrupting the burden on the healthcare system. We're empowering patients to not be caught unaware. And I think from the face-to-face interactions that we have with patients, that has to be like the biggest motivator. If you are sitting across from a patient explaining to them that they are most likely going to lose their toe, or they're most likely going to have an amputated limb because the vascular damage from the unmitigated progression of diabetes is just too far for us to save them now. It's devastating to have to present that when we know how to prevent that. And
yes,
that is not something that we should be comfortable with in the 21st century, when we have a problem that we know iterates millions of times in millions of patients. And we know this will lead to these bad sequelae, but we do know how to prevent it. If we can have these conversations with personalized guidance in time, we owe it to our patients to onboard a system that enables that kind of personal red flag to go off in time to change the path before it's just treatment of a terrible, intolerable symptom. And I think that is such a more exciting view of medicine than the medicine that is being practiced right now.
Yes. Yeah, no, absolutely. I think that the handy tool that I kind of use when I'm trying to describe it to non healthcare focused people is, in the medicine of the averages, the FDA approval rubric basically says we're going to look to approve things that apply to 1.96 standard deviations, which, if I remember correctly, is 95% of the population. Well, that would be fine if the vector of impact for any condition was one thing, then you'd only have to worry about 5% of the population that's an outlier. But if the vector is doubled, well, that's 95.95 squared, 80 something percent. If it's 0.9, if there's three factors, it's 0.95 cubed. It doesn't take too many contributors to a condition before that average only applies to, 80%. Forgotten the math on the limit of 0.95 multiplied by itself in ad infinitum. But you can see how that medicine of the averages starts to fail pretty quickly. And I'm reminded of the mRNA vaccines that were developed initially, and the PCR tests that were developed at a certain level of specificity and sensitivity that strongly promoted positive assessment at the risk of false positives. They didn't care about false positives because they wanted to nail this very scary then virus. The early testing, as I recall, had a 40% false positive rate. Well, that means you have to take the test 3 times to get a positive that's even remotely reliable. And yet we moved the entirety of the World Healthcare Organization and the world economy based on an inappropriately and solely relied upon single test of generously nebulous conclusion. I would love to hear your reaction to that. But when I looked at that as a math guy, I'm like, good God, what are we doing? Now, I am a strong supporter of vaccinations and of the mRNA pathway, but we can't, from a policy perspective, we can't manage healthcare in such jerky, discrete steps.
It actually gives us a really exciting opportunity to engage with the public, because I think a lot of people are either cautiously accepting or in some cases downright skeptical of being averaged into these kinds of public health policy decisions. Whenever we talk about something like a public health policy on vaccinations, a public health policy on food safety, a policy on particular additives, even growing patterns in agriculture where we set policies for the amount of pesticide use on a crop meant for human consumption. All of those boundary conditions for what constitutes an appropriate amount of intervention, an appropriate amount of mandated public health intervention, is based on average risk profile. What kind of intervention can we appropriately demand to reduce the average risk profile? And the individual, whether it is a person with their personal healthcare concerns, whether it is a parent with a child, the individual who might be on an immunosuppressant who's not sure if a particular intervention is safe for them, all of these things involve a patient or a person in the public sphere feeling like their individual makeup, their individual risk factors don't matter because they're not being taken into account when we make these policies based on population averages. And we kind of have a way of testing out what is an optimal regulatory requirement or exception when we think about the fact that we know there are patients where a certain intervention is not appropriate. When we have a child born with a congenital immune deficiency, when we have a patient who has been the recipient of an organ donation, and because they're on a transplant immunosuppressant, they don't qualify for a particular health intervention because that would endanger their immune system. We start to realize if there are boundary cases where an individual should not be lumped into the rest of the population, how many different unique individual health parameters should we take into effect if we had unlimited computational power to actually assess each individual risk? And we, unfortunately, in public health, have never had the capacity to evaluate that. We don't have the capacity to say, hey, according to your actual suite of personal health information and genetic risk factors, this is an optimal intervention both for you and for the public, because we just have not had a way of incorporating, collecting, or interpreting that much information at a population level. So I think we're literally coming into a time period where both the public really, really, really wants more personalization of public health policy, and also for the first time, we have the ability to collect and interpret that much data. So it's kind of exciting that we can look for answers that we could not have even asked the questions just a few years ago.
Yes, no, that's a great point. And it's interesting because population health sometimes among some communities is a panacea and among others gets a bum rep, right? But there's a concept in business called mass customization. Ordered a pair of Air Force, is it Air Force One? I'm really dating myself here, but the Nike shoes that are popular now, you can now order them and they are made within a number of days of you ordering them, customized along, I think it's 52 different dimensions at the same retail price that you would buy them on the shelf in Dick's Sporting Goods or whatever. We have enough data and enough actionability now in healthcare to actually mass customize population health. So it's no longer population health ruled by the averages, it's population health ruled by the knowledge that the farming family in central Indiana has an entirely different set of environmental and lifestyle contributors than the young professional living in New York City, in Midtown. Entirely different. And so the presentation of their health vectors of impact don't even look like the norm. They're totally different. Well, that's what Nassim Taleb says. Don't be fooled by the average. There's black swan event isn't really a black swan. It's predictable at very small numbers of activity. That's what the 3 billion base pairs of the DNA do. And I think what we'll see probably in 3 years. I was going to say 5 to 10 years, but I think we're rocketing forward with AI. What we're going to see is the confluence of those two general trends, which is understanding of the genome kind of multiplied by AI's ability to synthesize that much data and create a lifetime personal health plan for Matt David, a lifetime personal health plan for Jim Wallace, which I hesitate to go this far, but I will, begins at birth. At birth what your mutations are, changes in the DNA as we age. You mentioned one in a prior conversation about sunburn. That changes so much of your DNA that a lot of things go on in your body that we've evolved to handle. But multiply that times every environmental trigger that you face every day. I'm not saying environment is the cause, but the littlest thing could be the trigger for one or two people. And now we have the ability to synthesize that data, deliver it as an insight, not through Epic, but through other platforms like Persivia or like I mentioned before. We have the ability to deliver that to the doctor to say, I know this isn't on the United Healthcare care path, but you probably ought to look at this. I have a story. The founder, or one of the founding team, I should say, of DecisionRx was on Lipitor for 25 years with gradually increasing neuropathy. And it was a conversation with a genetically informed pharmacist that said, I see they've upped your dose. Do you have any cramps or leg pain? And he's like, God darn, yeah, I do. And they did a PGX test and figured out he, couldn't metabolize Lipitor as well as the alternative. And so they prescribed the alternative. Problem solved. That random insight is now available through AI to be delivered you don't have to wait 25 years for that anymore. That's what I'm most excited about, is reducing the time to market, if I use the business term, of solutions and introducing them in a mass customized way so I can order my healthcare like I can order my Nike shoes and have it delivered immediately. So you avoid the situation my mother-in-law had where she got the blood chemistry report and understood it before her doctor did. That would be embarrassing to me as a physician. It should be embarrassing to all of us that that's the way the healthcare system works. And part of that's uniquely American, I think, not to beat up on the good old US of A, but the way we finance healthcare has caused that. There are models to get around that. The DecisionRx model, if I can use that one for an example, the savings, since 100% of humans can't metabolize something, if we just focus on the top 20% of polypharmacy candidates and create a guaranteed $3,600 per member per year in value, that's guaranteed by research at current costs. It inflates each year. But that savings alone is enough to fund preventive medicine for the other 80% that becomes a snowball of savings effect and improved quality of outcomes and improved patient symmetry that just changes the paradigm altogether. I've been studying this for 15 years, just this. I can't even comprehend what that next level of value is. I think as a clinician, you probably have a lot better perspective of how that changes care delivery. But as a business person and someone who's actually financed those types of models, we're now at the point where customization is financeable. And instead of investing in that fourth generation titanium hip, that it's valuable, but we can invest the same number of dollars in immunotherapies that are still after the fact, a lot more pointed in their effect. Targeted therapies, we can invest in education programs and other things that help connect the consumer to their own health. That's just groundbreaking and paradigm changing. I really am excited about that future. And that's kind of how we conclude in the book that the genie's out of the bottle. Now that we have information and an integrating layer with AI, if you're unhealthy in the future, it's probably a choice. And that carries with it a responsibility. That there are factors that may predestine you to have some type of malady or condition, but we'll also have the information to be able to get in front of that in ways that extend your life, not in days but in decades, simply because you're aware of that condition. That carries a responsibility. I know a lot of people might say, I don't want to know that. Well, let's at least give them that choice.
Two of the ethical things that we haven't really had the means to need to ask yet are, one, like you brought up, we started with the advent of some of the genome-wide association studies becoming linked to personal genetic services like 23andMe, giving the opportunity for this ethical conundrum. Should we want to know? Should our patients want to know or need to know or get to know or get to plug their ears and say, I don't want to know, when we do have a reasonably high probability of predicting a negative health outcome later on? That kind of ethical dilemma certainly sounds from the future extra biometrically enhanced, AI interpreted, personalized data world that we're envisioning. It sounds like that ethical dilemma is only going to be magnified. The clinical side that becomes concerning is kind of twofold, because as the data collection becomes cheaper, as the data interpretation becomes more widely available, the question I want to immediately sort of parse becomes, when the solutions aren't as affordable as figuring out the problems, what do we do when we face this divide in the road where I can now cheaply tell all of my patients from all socioeconomic strata, hey, this is your percentage of probability of this terrible disease. This is your probability of disease. This is your probability of disease. But only one of those three patients I just spoke with can afford either the preventative care or the intervention at the current cost. What do we do in a scenario like that? Is it the ethics of explaining it to only some of them? Is it the ethics of how fast we can change the cost built into this system so that there isn't a barrier to access for that intervention? What should we be thinking of as this sort of universally available predictive diagnostic information starts to come on board?
Yeah, I think a large part of the outcome is actually self-annealing. Taleb talks about fragile environments, which the VBC, the value-based care construct, is fragile in the sense that as long as you operate within the norm, you're going to get a normative output, but it's going to be populated by a lot of individuals that don't have anything, and then the occasional $1 million lower GI colorectal cancer that metastasizes. With DecisionRx, we are able to finance all tests just on the savings of the 20% that are most costly. And so what we found was, as soon as we introduced that to patient and provider populations, payers are a little bit slower, but they wanted to test 100% of the folks. Well, guess what happens when you do that? A couple of good things. It's not cost effective at the outset, but Thermo Fisher and the companies that make the tests move from 96 cell testing plates to different level testing plates. In the genetic testing, they test a different portion of the genetic output just to focus on the pharmacological impacts. And this is just in pharmacogenomics. You can do the same thing for pretty much any domain that's genetically related. But then business picks up the ball and says, okay, if you can guarantee me 96 samples, I can lower the cost of this test to, double digits instead of 4 times that, right? For, thousands of dollars. And then the more you do, the more customization occurs, the better the care occurs. We actually, again, uncorked a genie in the bottle. And the other thing about the leverageability of genomics is once you know it, your siblings ought to want to know it. Your parents and offspring typically want to know it. And so there's this just tremendously valuable positive effect to it starting down that path instead of being afraid to. And I think the noted investors, Apollo, KKR, Carlyle Group on Wall Street, are starting to see that, hey, if we advance funding on that, the reliability of the return as mathematicians, I can prove it's not as sexy as a 4th generation titanium hip or, a new prosthetic device. But that type of volume, 120 million people suffer from cardiovascular disease in America. It's non-communicable. If we could figure out what precipitated that and get in front of that using precision medicine, the savings from that make a big dent in the $1 trillion, $4 trillion economy. So I'm probably preaching to the choir to, you and your audience, but all we need to do is take that first step, liberate the physician to do those things, eliminate the 12 prerequisites that Medicare requires for a pharmacogenomic test, and do it on everybody. It's $108 for the test. The consult with a genetically trained professional adds cost to that. The medication action plan to actually change the medication adds cost to that. But I think Eric Lefkowski at Tempus is probably doing it the best in terms of a domain where they're implementing that. I know we're making headway, and there's a number of competitors in pharmacogenomics. Wearables is probably the driver I worry about most because that's the one that's closest to the consumer. You can sell a lot of Apple Watches, but did you really get compliance and adherence by just giving someone an Apple Watch? I know I started paying a lot more attention to something like meditation, which I never thought about. But meditation, I can't remember the exact figure, but meditation, just a practice of calming your mind several times throughout the day, accounts for 8 to 12% of variation, as I recall, in health care. I don't know why. Clinically, you might have an understanding of why, but the math is kind of irrefutable. And so but that's an intractable thing for me. I don't understand. If we just gave everybody an Apple Watch, would that take costs out of the system? I would ask you.
That's a fun proposal. I'm sure the public would presumably be on board with that. Well, I've raised concerns before about whether we can extrapolate that to the assumption that there will be like mass compliance either with data collection or with making use of that data for behavioral change, lifestyle modification, dietary changes. And I think there's good reason to think that at least in some way, when you present people with data in a way that they can see it without feeling like there is an interpretive barrier,
or a burdensome mother hanging over you, I might add too. Right.
Well, yeah, what you take away a little bit of I think in medicine, there's always a little bit of the concern that there's some sort of paternalistic component where the doctor is telling the patient, you need to do this, you need to do this, you need to do this. And it's empowering to the individual to be able to see their own data, to see, hey, there's not a lag time either. If I decide I'm going to go for a jog, I don't have to wait 6 months and remember to go on a jog every single day. And then 6 months later, go check out my blood work at my doctor's office to see if it impacted either my blood chemistry or whether my hypertension is improving or anything like that. If I have a wearable that gives me real-time information showing me that there is in fact a positive payout for behavioral change, there's this thing we all understand that rapid payout for behavioral changes is a welcome thing. When you do something and immediately see the benefits, it is much easier to convince somebody to do that thing again than it is to say, well, if you do it and then you do it 364 more times and then you come in the next day, I will compare your blood work to the previous blood work from the previous year. When you have a wearable and you've been jogging for 2 weeks and you're like, hey, my heart rate is just looking so much better, and you don't have to wait a year to see your doctor, man, you are really, really empowering people with a real-time motivation that isn't built into the way that we practice primary care, I don't have the ability to be there with all of my
Yes.
patients. It's just not possible. I don't have the ability to be like, hey, you really sat down a lot today. I wish you would go for a jog. But a wearable has the ability to remind a
Yes.
patient, hey, you need to walk around. You didn't hit your step count today. And there are just irrefutable studies demonstrating that simply remembering something as simple as doing the basic human activity of walking your 10,000 steps a day extends your lifespan. And that might be as useful or more useful than even certain kind of medical interventions that would happen later in life if you forgot to walk.
Yes, each of the 4 drivers is coupled with a vignette in the book, and in the wearables section, it deals with weight loss. These are they're disguised patient stories, but in that instance, simply understanding the protagonist there, Michael, just understanding that eating the candy bar every afternoon in the office caused his blood sugar to spike and his activity level to drop. You know this much more better than I do. Just understanding that, I have seen this in the data as a healthcare professional, caused him in that instance to make a minor change of substituting almonds or something else that had the reverse effect, causing his metabolism to be sustained, burning more calories. The wearables can do all of that for us today, and they seem minor, but they're all important. And I think the Aura Ring with sleep habits is another one that's just changing. Sleep, how you sleep has such an impact on how you wake and act during the waking moments. And the devices don't cost a lot. There is a barrier to access because not costing a lot is very different for someone living hand to mouth at the lower end of the socioeconomic spectrum. And we should probably invest in that. We should probably make that technology available to them because they're the most impacted by a lot of lifestyle considerations. But the people that care about their health now or can afford to are already engaging in that and making some of those changes. And each of the drivers, whether it's genomics or wearables or big data or AI, each of them have some aspect of that. And I'm excited about wearables, but the adoption curve as a businessman, I could just look at that and say getting meaningful, long-lasting change is harder at that level than it is to tell somebody you're at risk, you have the HER2 positive mutation, you're more likely to get cancer than others, right? So this is what we're going to do about it. It's harder with the wearables, but once they get it, it's more meaningful. And so I think in that instance, it's probably you're probably gonna have to push that a little bit harder. But once they understand it, I've seen it across reams of data that the lifestyle changes do register. So I'm pretty excited about that. The actual bad thing about wearables is the amount of data that it puts out, again, burdens the physician. And I've probably talked to, I don't know, 40 physicians who are like, the next person that brings their Apple health chart into me, I'm going to throw them out on their ear, right? Because some of that information it doesn't achieve the level of practical intervention, right? I would pause there, though, and say, I'm not sure if that's not an artifact of our reactive medicine system as opposed to an insight of a preventive medicine. I don't know that yet. That's kind of the follow-on to this book will probably be, okay, now we have all this data, this integration layer. How do we prioritize and eliminate barriers to access?
It's going to be a huge component depending on which portion of medicine we're thinking about, because there are different agents at different levels of care who have different capacities to make use of that kind of information. So when we see a patient who is at an advanced oncology center and we get a tumor genetic profile, we know that we need to look for a series of specific receptors that are predictive of specific medication responses. And we have the agency to actually modify care immediately on the patient's next visit to the chemo center when we are given that information. The more we build out this understanding of the way that cancer evolves, the way that individual cancer outcomes reflect different mutation cascades, different structural variants in a particular tumor, we have the ability to increasingly act in this very specific, very intentional way. And we leave none of that data just as a wasted sort of byproduct of data collection, because oncology is built specifically to understand that the individual progression of a tumor is responsible for the difference in patient outcomes. When it comes to preventative care, I think this is where it's so hard to predict both what the outcomes are going to be in terms of how much agency the patient has to actually be informed and act on that, and how many barriers there are left in the real world, in society. If I have 10 patients who all find that they have potentially disrupted metabolic curves in their wearable device data,
Mm-hmm.
but some of them can afford to get custom meals delivered with optimized
Mm-hmm.
macros every, Monday, Wednesday, and Friday. And some of the patients are living where they're in a food desert and they don't even have access to the kinds of fresh fruits and vegetables and high fiber diets and things like that that we're encouraging them to adopt
Mm-hmm.
in response to their data. We're facing a system where the data is going to start to bypass, at least that would be my concern. The system is going to bypass the ability of these social systems to actually provide options for the patient to respond to that data.
You
And
know
I
what,
don't know how
though?
we do that yet.
You're onto something. In my doctoral work, we used machine learning to do a augmented meta-analysis of many studies on unexplained variations in outcome of care. Two things that popped out. There's a noted study out there about, I believe it was done in New York City, of a cohort of older females that were Dominican of a particular order of Catholicism, and they all had advanced presentation of late stage breast cancer. I don't know if I said that right clinically, but their cohort had more instances of metastasized, stage 2, 3 cancer than they should. And when the principal investigators looked at it, it was because their faith led them to believe that it was God's will. This concept of destino, the Spanish word for destiny, said, well, I have it because it's God's will. And what they did is they introduced a Catholic member of the clergy into the care path to say, God doesn't want you to have cancer. It's okay to self-exam, because their faith was telling them that was not a good activity. They eliminated the aberration in advanced care in 2 generations just by introducing another member of the care team. So I think the social fabric has the ability to absorb the data. It's whether we have the ego to let go and get the right party involved. Another instance, insurance agents. When they're selling the health insurance policy, unless you buy it over a telehealth center, which can still, our emotive cognitive AI layer that I'm developing can deduce these things just from audio and visual input remotely. But insurance agents in a home selling a policy, a Medicare policy, get reams of information that they don't know they're getting that can help steer that person to a more or worse plan. I don't know if you're familiar with the Medicare space, but they have special needs plans that focus on specific categories of illness, and yet nobody's using that data. One of the companies I founded actually erected that same financing mechanism to say, well, let's just start looking at that data and predicting how long that person is going to go without a claim. And once we uncovered what the drivers were and started associating them, we started sharing that information with the insurers, who then created programs, I mean, to be candid, to avoid the risk, not to deal with it on the payer side. But now that you know that, you could be a lot more effective as an insurance agent saying, listen, I could sell you this one policy, but you really need a cardiovascular oriented special needs plan, or a diabetes oriented, or one of the chronic illness special needs plans. It makes all the difference in the world, because now the patient's getting the right resources, which often includes preventive and preemptive medicine that just isn't available in the ordinary standard of care. I'm super excited about that. I think the market's still way off on fully implementing those, because I think I'd ask you again and your listeners, the last thing a physician wants to do really is have to wait on somebody else to drag into the conversation like a clergy member, even though it accounts for, 8 to 12% of the outcomes as meditation might. But we deduced in that AI meta-analysis, reduced it to 6 questions that you could ask on a Phreesia tablet at the patient presentation on intake that would tell them, are they at risk of any of these secondary drivers of socioeconomic determinants of health that could really vary the outcome. It's being implemented by a few carriers, but again, it's at risk avoidance, not outcome manipulation. So we really need to round that corner. I think AI is going to create the elephant in the room where we have to deal with it because now we know. And it also will solve it from integration layer by helping physicians like you and your peers really synthesize and determine signal from noise rather than just like the Chronicle did, dumping a bunch of aberrant heart rhythms onto a doctor's pager or Apple iPhone interface. Does that make sense?
There are so many different socioeconomic factors that I think we have some perception that they can influence patient medication compliance, lifestyle factors. The hard part clinically is that a lot of times we really truly don't have a grasp for how they impact the outcome for the patient. And I think the exciting thing about this personalized, much more data enriched and AI interpreted future is that now that we have data showing that the perception that this patient has, whether it's for the value of a exam, whether it's for the value of a particular change in lifestyle or diet, whether it's opinions about the pure beliefs about a particular medication protocol, like there are parts of the country where certain parts of the population don't feel comfortable seeking out psychiatric care because
Sure.
there are beliefs against use of pharmacological substances. And when we understand that those kinds of things are barriers to care for our patients, I think as clinicians, we can feel more comfortable addressing them head on and saying, hey, who would be on board? Who, if they were on board, would help you make a decision that would better your outcome? And the fact that those influences are supported by the data is also, again, really, really empowering, I think, for the physician and for the provider. Man, what I think this is an exciting era to be entering in medicine. And I think for the very first time, we're seeing a kind of change on the scale that maybe you can convince me we're not going to lose the battle to chronic disease, because this like ongoing conversation about how we have the best surgeries now and we have prosthetic valves and we have all these cool pharmacological new agents on the market. Always we loop back around to, yeah, but the individual patient keeps getting swallowed up by this chronic disease wave of the 21st century. Do we have a realistic chance of fighting back now?
Yeah, I would say so. I think that it's because we're empowering the patient with data in ways that the patient can understand at least enough to ask the appropriate party, their physician, to help them. But that's each section of the book ends with a what you can do today in a section, because it really does depend. And that, again, my doctoral work, it depends on the internalization of one's health efficacy. You know this better than I do. I could identify factors that predispose someone to a particular condition or outcome. I could warn them of the triggers, and they may still elect to expose themselves to the lifestyle or environment that does not reduce that. But as, again, Taleb would argue, or I think even Richard Dawkins, the eminent evolutionary biologist, you're better off sharing that and letting the chips fall where they may than restricting that in a fragile system kind of way, like value-based care, and ignoring it. Because at least then you're arming the individual, the patient-provider pair, to make an informed decision. The ultimate barrier to that, I think, is suppressing it, or maybe the tail end of individuals that will choose not to act on it. The smoking problem, right? We still have smoking, even though people know its effects. But I'd probably rather live in that world than one that eliminates the decision to engage or not. And I think, unfortunately, it's so funny to hear critics of like national health system in England or the Canadian health system in the States. It's interesting to hear them say how top down and nasty those types of organizations are. But we've really created the same thing with value-based care, and we're turning our blind eye toward it. So I think the release of information that's coming and unavoidable has reached the tipping point. And so we're beyond ignoring the elephant in the room And we're to the point now where we have to decide how we want to act on that. I think that change is going to be provoked by those four drivers: wearables, genomics on the data side, and then big data and AI as the integration layer. That's changed the environment. We couldn't have done this 20 years ago. We could have done it 40 years ago. Genomics existed then, but we didn't have the information systems to really act on it, right? So yeah, I'm pretty excited about that. I'm excited about two things in life. One is that our children's healthcare is going to be a lot better than our own, and they're going to be the stewards of their own outcomes. And I'm excited about exploring Mars. My time at SpaceX, some exposure to the Starship program, and it's really just fascinating to see us become a multiplanetary species. So, but I digress.
I think the appreciation that we have for data in the 21st century in many ways comes from the fact that we see frontiers we didn't think were even open to us have become open to us. We have to make reference of space exploration. We have sci-fi representations of things like rockets inverting their flight path and landing backwards, going back over half a century. Like this was one of those sort of sci-fi level engineering impossibilities that we envision 200, 300, 400 years in the future might be a possibility. And when computational systems started to be able to predictively evaluate flight paths at the resolution that they could use integrated flight data to flip a rocket over and land it on its tail, the entire space industry flipped. This new information processing power enabled something that seemed impossible. The challenge that I think we face, and if I can give some evolutionary pushback to this, because I live in a world of biotech optimism that I have to constantly sort of push back on, is I love the optimism. I love the excitement. I love the new frontiers. But in an engineered system, we have the ability to scrap completely anything we want to, from the material components to the actual, not just software that we're running on it, but the actual computational hardware. And the thing that we cannot escape in medicine is we can never escape the fact that we are on an evolved hardware. We are inheriting the body plan in the genome. We're inheriting the body tissue. We're inheriting the neurological structures that helped our ancestors survive in an environment that was completely different. And one of the sort of overwhelming realizations that you have when you live in a 21st century environment, when you have a patient come in and tell you, I can't remember the last time I drank water. I think it was in maybe the mid 1980s. Because man, sweet tea is just so delicious, or Coca-Cola is just the best thing that ever got invented. And you realize, our ancestors lived for countless millennia in an environment where they only ever had access to water. It was the liquid. If you wanted to drink liquid, you drank water. The very concept that your body should be able to conceive of drinking calories was not something any ancestor of ours ever had to deal with until very, 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 very recent times. And the idea that our brain would ever have to have an appropriate limiting response to a glass filled with high fructose corn syrup is something our bodies and our brains were not adapted for, because this was a stimulus that was completely absent. In like classical sort of island evolutionary biology, we teach kids about goofy species like the dodo bird that evolved to be very slow and flightless, and they were absolutely unprepared for the onslaught of sailors who would come and club them to death and roast them over an open fire, and they went extinct incredibly rapidly. Right. But in many respects, human biology is just as unprepared for the onslaught of the kinds of food and beverage exposures that we have in the 21st century. The thing that I would say is a sort of real evolutionary medicine informed concern about the optimism on the diagnostic and informative side of this new sort of AI information revolution in medicine is that if I walk into a clinic and I present 10 patients with their personalized genome, I present them maybe even with a microbiome study, and their wearable data has been summarized from the past year. It is really good information. It gives their prefrontal cortex in their brain some things to chew on, to consider. But in no way, shape, or form does that change the neurobiology of sensation when they're drinking a cold Coca-Cola, the pleasure of the limbic system when they just hear that can popping open, that sort of addictive profile that highly super sweetened foods brings. And I feel like one of the areas of sort of this new AI revolution that I hope somebody funds and I hope somebody works on is figuring out how we can use the knowledge that we have of our evolved biology, the knowledge that we have of the addictiveness of like hyper sweetened foods and the pleasurable sensation of eating a bready item that has just every last bit of fiber taken out of it. So it's just extra soft and squishy on the palate, and helps us to actually figure out what are the actual data supported ways to modify behavior in a way that gives the patient a realistic chance for long enough to actually rewire their neurobiology, and what kind of support can we give them when their actual biology of their tissue in their body has been disrupted. We like to tell patients, we roll in and we're like, hey, check out your wearable data. It shows that when you eat that candy bar, your glucose spikes. The problem is, if you've been doing that for 20 years,
Yes.
you have a population of adipocytes where they're ready to store all the extra calories.
Right.
And an adipocyte can live 10 to 15 years.
Okay.
So that cell is sitting there going, hey guys, let's send down some extra
Let's
calories.
do this.
And it's going to hover there. Even if you starve it out for a couple years on your Ozempic or whatever you're taking, it is hovering there for the next 10 or 15 years, just waiting to fill that fat vacuole back up and have those extra lipid stores. And I hope, my hope is, my pitch to all of you guys who are doing this great work on making the next generation of precision AI medicine, don't forget, we're not engineered systems. We are these like evolved creatures who grew up on the savannah of Africa, and we're not really sure how to like change our habits in the 21st century surrounded by modern grocery stores.
Yes. No, that's a great point. And that probably brings us full circle for me, because I kind of started my journey with two futurists. One was Alvin Toffler, 1970, said, when Future Shock said said the same thing you just did in a different domain. He said, humans are not adapted to the amount of information we are generating. And he predicted a lot of the things that are happening today with social media back in 1970. And then second, Richard Dawkins in The Selfish Gene in 76 basically said, we are an organism that supports the gene. It's not the other way around. And if we tilt our thinking to remember that, the implication of that's a lot more complicated, to your point. There are mechanisms that have evolved inside of us that actually prevent GLP-1s from working, because as soon as you stop taking them, that particular structure is going to immediately say, fill me back up, right?
Yeah.
And you're genetically programmed. And in Richard's latest book, The Genetic Book of the Dead, he basically says that if you look at our genome, it is a map of how we got here that's instructive of how we have to act, given that we're genetically inclined having gotten here. That's probably two layers of abstraction that I struggle with a lot, but it really says the same thing you just did. And I would encourage everybody to read the book, because he does a really good job of explaining that in layman's terms, that to ignore what you just said is to create a system of healthcare that can't be preventatively successful, because all you're trying to do is suppress embedded genetic learning that's virtually impossible to suppress. It's like literally, I would ask you in closing, literally impossible to reverse. It's always going to be there waiting. The best we can do is prevent, or the best possible thing to do is to prevent the trigger, to prevent the development of those cells that are going to be craving that as soon as you go off the GLP-1 agonist.
This idea that contingency plays such a big role in medicine hasn't yet sunk into our psyche as providers or as patients, that the earlier we can use this new precision personalized AI medicine to keep us on the right path, the less we have to fight back the layers of damage that has accumulated in our body. And then for anybody who might be listening to this podcast who has any role whatsoever in engaging in any way with the kind of social factors that surround young people, with factors that purposefully prey on our adapted dependencies, our adapted proclivities to seek out inactivity, to seek out hyper sweetened foods or low fiber foods, that any social change that we can pair with this new 21st century medicine so that we're not fighting as extreme an uphill battle, the synthesis of those two things, the synthesis of looking backwards to understand the biology that we were adapted to have, and looking forwards at the information science, the AI, and the personalized medicine to give us the best opportunity right now, that's where we're going to find a healthier population tomorrow.
Yes, that's exactly right. That's pretty much the summary of the last couple of decades of my work. Is I can come up with endless examples, but I think we're at the tipping point where we have enough access to enough information, and to overcome Toffler's concern, we now have an AI that's able to separate signal from noise in actionable ways and feed that back to the patient-provider nexus and say, do you want to act on it or not? That's the best we should hope for. I don't argue in the book, or just every day, I do not argue for a prescriptive system that's overly burdensome. You end up with the opioid crisis then. I mean, just the whole segment, I'll stop here, but the whole segment of, NSAIDs and inflammation suppression. Inflammation is an evolutionary construct to deal, right? That's telling your body how to respond to something. And we have a whole class of medical intervention that deals with suppressing that. I'm not saying there's not a time and a place to do that. I'm saying that jerkily embracing something before you really consider how you got to that point is traditional medicine. Precision medicine pauses and says, how did we get here, and how can we avoid you from getting any closer to the I'm enormously excited.
Tell us where we can find your upcoming book.
Sure. The book is Precision Medicine, AI, and the Science of Personalized Healthcare. If you go to Amazon and look up James Wallace and Precision Medicine, I'm sure you'll find it. Wiley is releasing it for print in September, so we're still a couple of months out. But I'm doing a lot of outreach right now, speaking with a lot of people about it and finding a lot of audiences. So I would say order the book today and sign up to get the pre-releases of the chapters, and we'll start kind of unpacking wearables, genomics, big data, and AI for practical use. There's a lot of people that are receptive to doing what you're advocating. And so I'm just encouraged by that. There's always the sense that, and I think Gen Z is probably unfortunately mislabeled, that they don't want to do that. Well, no, they just don't have the information. And if you arm all of us, like Susan, the 64-year-old woman with cancer in the fourth section of the book, all of her triggers and her life has already occurred. But just identifying the genetic cause and associating that with a monoclonal antibody, I think your generation and the generation of researchers, physicians, patients are actually going to be more receptive to that. And I'm super encouraged by that. So thank you for having me on the podcast. I love this, and I look forward to talking with you again.
Absolutely appreciate it. Thank you so much for taking the time to chat with us today.
Awesome. Thanks.